Next, we're going to get our discussion panel going on waterborne infections in healthcare. For this panel, we have Dr. Jimmy Walker, Dr. Girly Manatad, Dr. David Krause, and Dr. Molly Scanlon. Our first speaker in this panel is Dr. Jimmy Walker. He is a scientific leader in water microbiology and decontamination at Public Health England, Porton. He has 29 years' experience in public health microbiology with an extensive publication record and is regularly invited to speak at national and international scientific conferences. Dr. Walker leads research projects at Public Health England and is particularly interested in the development of rapid technologies to assess the presence of opportunistic premise pathogens in water. He advises hospitals on incidents and outbreaks associated with waterborne pathogens such as Legionella, Pseudomonas, right to our last question, and mycobacteria. He works closely with the Department of Health England and public health safety executives in writing and developing national and international guidance on the microbiology of water and healthcare. Dr. Walker also works with the Department of Health on decontamination guidance in primary care dental practices, endoscopy, and surgical instruments. Dr. Walker.
Thank you, Jesse. Good morning, everyone. Are you enjoying the conference? Are you having a good time? Good. Are you enjoying the science? Wasn't that last presentation just fantastic? Not every time you get to talk about dribbling diarrhea before 9 o'clock in the morning. So thank you for that, Dr. Weir. I'd like to thank Chris and Savannah for their invites to come and talk to you here. It's a great pleasure to come and share with you some of the work which I've carried out with colleagues, and a large number of colleagues, some of whom are identified in these slides. And I was thinking about sort of disclosures. We have got some major water systems at Porton, where I work for Public Health England. We were given in kind the taps from here from Dart Valley for that tap rig, which I'll talk about the implications of in a few moments. And then we've just started another study looking at traps in clinical hand wash basins. And that's been, most of the work there has been donated by Ideal Standard, but no cash as such. So I'm going to talk about waterborne infections, Pseudomonas, Legionella, mycobacteria, but mainly in the remit of what a water safety group should be and what a water safety plan is and has to be put in place to protect you and your patients. And it's something which struck me from a gentleman called George McCracken, who was involved in the incidents of neonatal deaths in Belfast, who said, "Are you compliant or are you safe?" And I've turned that round to, are you compliant or are your patients safe? Not just you or your staff. So the implications are, yes, you might be following the guidance, but are your patients actually safe in your institute? And that's the theme I want to set for the rest of the talk this morning. In Belfast, it was a tragedy. It was 4 neonatal babies died in a number of incidents. They weren't the exact same strains as determined by whole genome sequences, hence they were incidents rather than outbreaks. But 4 babies died. It was catastrophic for the hospital. We have major incidents with Legionella in the UK, as you do here as well. Hospitals being fined, the estate staff being fined and potentially jailed because of the implications of patients dying. It was mentioned yesterday about, or even this morning, the change of water source. You know the consequences here with Flint changing the water source and not carrying out really in detailed risk assessments as to what's going on with that water and implications and the growth that could occur in that water. In this case, amongst other things that went wrong, the growth of Legionella and people dying. And then the cooling tower incidents in New York, again, resulting in a vast amount of management systems now being put in place. And we've been through this in the UK, and I'll talk about some of that guidance in a minute. Dr. Weir touched on the fact that we're not controlling Legionella. 1976, first outbreaks in Philadelphia. Here we are, virtually every year for the last 4 or 5 years, we're seeing slight increases. It's quite ironic. We're putting these management programs in place and we're not really getting the control we need. More recently, I've been doing some work on climate change, and the last 16 years, we've had 10 of the highest years in terms of temperature. Is there a link between climate change and Legionella? I don't know what the reason is, but we could be seeing more growth for a number of reasons. I don't know about that one. We're very, very lucky, all of us are very lucky in having this guidance, which is terrific guidance from the World Health Organization in guidelines for drinking water and managing those drinking waters. We talked a lot about that in our focus group yesterday, how there's fantastic disciplines in place in ensuring that 99.7% of water samples delivered to your building are safe for the occupants of that building. And these documents help to put that in place. We're very lucky in the UK. We have our health and safety executive, and our approved code of practice. And these are fantastic documents and backed up by not only cooling tower documents, but also the control of Legionella bacteria in hot and cold water systems. And there's a lot of this I'm going to draw on today, which is going into other guidance. But the important thing about health and safety executive is the statutory requirements and that you have to follow their guidance, and it's for protection of people in all buildings, not just healthcare. And if you get people in your buildings who contract Legionnaires' disease and your system hasn't been managed appropriately, they will take you to court, they will fine you, and they will jail you. And they do not have to recover the microorganism. You just need to prove that you are not managing that water system. That's an important implication that we all need to bear in mind. So it's a bit more soft guidance is from the Department of Health and Health Technical Memorandums in the UK, and it's that's going to set the scene for the rest of my talks today. And the question from Patsy about Pseudomonas aeruginosa was very pertinent, because following the outbreaks in Northern Ireland in 2011-2012, the Department of Health put in place the guidance for Pseudomonas aeruginosa. We had nothing in the UK, in fact most of Europe, for the control of Pseudomonas aeruginosa, and it's slightly different from Legionella, and we're going to pull those parameters out for you today. But basically what we're looking at is a healthcare trust, where the duty holder, the person responsible for that trust, has to put in place a water safety group. And I'm going to talk about the implications of that and who should be involved in it. And it's basically allowing the water safety group to control the safety of that water and reduce the risk for patients and also for staff. But it's ensuring that the expertise is in place to allow them to do that. And that's why I think I've really enjoyed coming here and working with many of you over the last, what is going to be 2 days, because it is the type of multidisciplinary approach that we need in order for this type of strategy to work appropriately. You need everybody involved, not just single entities. So what is a water safety group? Microbiologist, infection control, your facilities management, your estates management. You need your core group. But then when you have incidents occurring or particular aspects of problems, you need to be able to bring in your housekeeping, your specialist departments like dialysis unit. And I'll talk about a dialysis unit incident later on. It's important you have to bear in mind that there's some vulnerable patients in your trust that you need to protect more than others. And then we'll talk about risk assessors as well. But how does this all play out? Basically, as we've implicated this guidance, and we heard some fantastic talks from Leslie Myers yesterday, and the implications of putting something in place which is top down. So this is Department of Health guidance, asking people to put water safety plans in place. And some of them have struggled. And that's why I like this slide, the blind leading the blind, because when it's all put in place in the first time, people don't really know where to go. But you have, like the expert showing this photograph, and this reflects all of the people in this room. They are all fantastic experts in their own right, and they have to bring their own discipline to the table and leave their agendas and their egos outside. This is about patient safety, not about how important you are as an individual. So, you need a chairman. I'm not sure I'd ask Kermit to be the chair, but I think I know in this room who I would ask. I did ask Chris permission. I'm not quite sure she understood what I was going to use the photograph for at the time. But basically, you need someone with authority. You need someone who has the ability to react and work with the board of directors, because that person who's chairing that group is going to be communicating with them. You need someone who's able to ensure minutes are taken, that those records are kept for appropriate time periods, but also the written record in terms of the safety program was put in place by the experts who are required. You need up-to-date plans. Has everybody who works in a hospital got up-to-date plans of all the water systems? I hear a bit of laughing in the background. I think this is why the panel who's been picked are who they are, and understand the implications of what we need in place. The skills. Many of you in this room have skills. Can you actually demonstrate that to someone when you need to? Do you have the certificates of the training that you need? The conferences that you went on, the things you learned, and obviously your vocational training. Because at the end of the day, we have to empower the staff within the hospital to be able to say to clinicians, you must change those gloves again. Chris, you touched on this a number of times. You touch something before you go and you have to take them off before you go and touch the patient again. You need to empower the staff, because it is the vulnerable patients who are at risk and need to be protected. So hands up those who work in an institute who recently had refurbishments, rebuilds. Oh, not as many. Yeah, okay. So this goes on all the time. And we need to make sure that when this occurs, that the water that's supplied to the outlets, regardless of where it is still safe for purpose. And this image of James Bond, Man with the Golden Gun, reflects what is often my interpretation of companies who have control strategies turning up, knocking on the door and saying, I have the best thing in the world, this is going to control all your problems. And it doesn't always work out like that. They have to understand your water system and what's going on. So design and refurbishment, as much as the people within the water safety group, they're not architects, they're not designers, but they have to understand at the end of the day, when that design and refurbishment is finished, they have to accept the water and the system as it's been signed off. In order to do that, that has to be microbiologically monitored, and sampling has to be carried out in order to do that. But importantly, that system should have been disinfected before sampling, and hopefully, any samples taken shouldn't be taken for 48 hours after that disinfection process. Otherwise, you would just be testing the disinfectant, and that's important to remember. Also, if you're getting sampling done, get it done by an independent organization, not the people who are doing the management of the system for you. So we talked about competencies of risk assessors. Again, it's how do you demonstrate that? Have they had accredited training, or is it just something they've picked up through their careers? Can they give you examples of the recent histories, institutes they've worked in, either orally, presentation, or in hard copies? But importantly, do they know enough about the statutory documents which you need to be regulated to in terms of your governance for them to interpret and ensure that you are keeping your patients safe? Whether it's in the UK with our HSG guidance, or in fact with the ASHRAE, for example, 188. So in terms of a risk assessment, it should identify the relevant problems in a system. And that's why these people need the broad experience which we're asking them to have. Because they need to understand that if they're asking you to put corrective prevention in place, that it's actually going to work. And it's not something which just someone's invented and they're going to use you in your institute as a guinea pig. And then ensuring that monitoring is in place to demonstrate that microbial control is actually effective and working. We'll talk about the hot and cold water systems in a couple of minutes. But one of the things I quite often get asked on is, what happens if I have a water failure supply? What happens if there's a mains break? What happens if, and I couldn't believe this, Dr. Weir, you're really still using wooden pipes? I haven't seen a wooden pipe for a very, very long time. I thought they went out with the Romans. So if your wooden pipe fails, how are you going to supply that water to the wards? Do you have a contingency of bottled water supplies, tanker supplies? Are you talking to your water supply company in the event that that happens? And towards the end of the talk, I'm going to talk about data management. This is something we feel is extremely important, and it's not just the microbiology, it's all the factors of your water system. And using that data intelligently so you're not just faced with a whole load of spreadsheets. And then you have utilization and stagnation. How many people have ever been faced with this? A small ward or isolation unit that's been turned into a storage unit, or the hand wash basin that's behind the door as the door's open and the staff don't use that one because it's the proximity to the door. And this is a fantastic set of shelves which a carpenter and the hospital obviously built. Anyone know what they're looking at? Tub. Thank you, sir. So the implications here are, we talk about stagnation water and little used outlets. These are actually just dead ends. These will never be used. This will never be used. But the implication is that if you've got Legionella or Pseudomonas growing in these pipes, it will then seed the rest of your system, and it may take you a very long time in order to determine where that water is coming from. In the UK, for a number of years now, we've had a real hatred of flexible pipes because they were used everywhere. Every single tap was connected to the copper parts of the system using these flexible tails. And they are a biofilm generating system. We've shown the growth of Legionella, we've shown the growth of Pseudomonas aeruginosa. This one's a pure Pseudomonas aeruginosa biofilm. This EPDM that's inside these systems, these pipes, is a fantastic nutrient source for the organism. So don't use them. You can use them in appropriate situations, but please not on a regular basis. We've had anecdotal stories before of clinicians having ordered new tap outlets and fitting them to their basins and finding that they're immediately getting Pseudomonas aeruginosa. And it's all always been anecdotal. In our lab, Chloe Hutchins had just carried out a study where 7 of the 8 taps which we got delivered to the Institute for her experiments in the tap rig had Pseudomonas aeruginosa already in them. This is something we need to work with manufacturers. We need to ensure that they are using water when they're testing the system. They have a disinfection system to wet test their taps, or ideally, if they could, air test them. Let's not be delivering Pseudomonas aeruginosa to our hospitals give ourselves a chance of controlling it. And then you've got things like pipe capping pipes. This is something we've just more recently introduced to try and prevent debris and nutrients from being deposited inside our pipes before they're fitted to the water system. In terms of storage tanks, I've sort of not put up any horror pictures of rats or pigeons in the water tanks this time. We've moved on a long way from that, I think, in the UK. Your cisterns should be capped, there should be tight-fitting lids, there should be sieves in them to stop flies, nutrients getting in them. But we still have incidents, and this was one of the recent ones in the UK, where in fact it resulted in an alert going out from Scotland. And these plastic pipes, the stanchion pipes, were supports for the lid of the water tank. And basically what was happening, the water was going into these stanchions and then not really moving. And the deposits and the sediments that were in the bottom of the tank were resulting in Legionella growing in the bottom of these stanchion pipes. Again, seeding your system, because your cold water tank is then going to be feeding your cold water system and your hot water tanks as well. So the implications are there. You will contaminate your whole water system. Ideally, your water system should be kept at cold water system at 20 degrees centigrade. It's not always possible. You might have to run the water for considerable periods of time to get it below 20. But as you go above 20, you start getting microbial growth. And this is one for the architects and designers. I think it's a bit of a wish list to say, let's not run the cold alongside the hot pipes. But can we actually manage that better? Can we actually make a separation there to prevent that heat exchange? Maybe we can, but maybe it will cost a little bit more. Or we should be running the cold just more inches away from the hot to try and separate that. In terms of the hot water system, primarily we're looking at the hot water as a control of the microorganisms in the water system. We're looking in the UK now, calorifiers at 60, minimum 55 degrees in flow and return, and minimum 50 at the final connection back to the calorifier. Depending on whether you've got non-touch taps or manual operating taps, if you have manual operating taps, you have to have a risk assessment to prevent any scalding that's being placed. Where there's whole body immersion or showers, then you need TMV3 valves to bring that water down to 40 to 41 degrees centigrade. Otherwise, you can ask the staff to assess the risk of scalding where only the staff are involved with those taps, and we'll come back to that in a couple of minutes. So we have a lot of components in our water systems. When you get down to it, they're extremely complex systems. This is a sieve, which is placed on the side of a tap. You can just see here the accumulated material on the inside of the sieve, which is positive for Pseudomonas aeruginosa. This is about ensuring all your components are serviced, and only through doing that will the plumbers ensure that the system is clean or identify where you're getting debris build up, where you need to take a closer inspection of it. So these were a schematic of the non-touch tap systems, which would have come from Belfast. We had hundreds of components come from Belfast, and these were the components which are most positive for Pseudomonas aeruginosa. So down the bottom right, you have your thermostatic mixer valve, your cold coming from the left, hot from the right. 4% of those were positive for Pseudomonas aeruginosa. We didn't need a culture plate. We didn't need an SEM. There's nice, gooey, chewy biofilm on here. And it's even nice and green. It's given us a good clue. 4% of those were Pseudomonas aeruginosa. And if those are positive, they would deliver water when people are washing their hands, which are positive with Pseudomonas. EPDM rubber diaphragm in the solenoid. So when you activate that non-touch tap, the solenoid will move out, it will allow the water to flow through, and it will then close. And that rubber diaphragm is there to stop water seepage. Again, it's so green, we know the Pseudomonas is there. 7% of those were contaminated. Again, allowing water to contaminate the water when you're washing your hands. And these were the outlets, fittings, plastic floor straighteners, which were found to be grossly contaminated, visually grossly contaminated. 60% of these were contaminated with Pseudomonas. And there was a major amount of research went into then trying to re-engineer these and change these and look at a better way of delivering water. But basically what we're looking at is the last 2 meters of the piping work in these situations being positive for Pseudomonas aeruginosa, not just the outlet. So you have to bear that in mind. One of the hospitals in Belfast then went to thermal control. And again, this was easy because they're already circulating the water above 55 degrees centigrade. They took the thermostatic mixer valves out, put in manual taps, allowed the staff to determine. And this was touched on yesterday about allowing staff to not only determine their own temperature, but determine the flow so they don't get any splashing. Remember we talked about that splashing impacts yesterday and dispersal. We're going to come back to that in a minute. The microbiological control is more than just monitoring the bacteria themselves. You need to be monitoring the temperatures. If you've got outlet basins which you think are infrequently used, you can put data monitors onto there to look at flow velocity, temperature to ensure that they're used. Ideally, you want up-to-date, accurate records of your drawings and diagrams. I'm going to touch on that later and why that's important. What assets do you have in your wards and hospitals? Do you actually know? Do you have a list? Have you any idea whatsoever what you need to? And then there's the training of the staff. Again, ensuring that your own staff are trained and competent and understand why we're asking them to do the protocols which we're looking at introducing through either HTMs and or through your Medicare system. They need to understand the implications of the microbiology. Biocides are an important aspect of any water treatment program. We use chlorine in terms of the supply water. But if you're then looking at introducing a biocide, does anybody within the water safety team have a background in biocides and chemical control? Because the people you're then bringing in to implement that system really need to understand your water system as an individual building and not a bolt-on system they think they can bolt on to any building. Every building is an independent living organism as far as I'm concerned, and you need to look at them differently. Chemistry, water, the microbiology, the flows, diameters, length of the pipes, type of pipes. So all has to be taken on board. And this is why if someone turns up to you and says, we have the most important and pertinent control mechanism, if it sounds too good to be true, it probably is. So please treat it with skepticism and do not assume anything. Your water safety group really need to be involved in not only just ensuring that it works, but ensuring that you protect the patients. And I said I'd come back to dialysis units. This was a hospital, Queen Elizabeth Hospital in Birmingham, where 2 patients died because they were treating the water system with chlorine. Chlorine should not be in the water in a dialysis unit. That was a mistake, that was an error, and 2 patients unfortunately died. That was preventable and should have been prevented. So thinking of Pseudomonas aeruginosa, and I'm not picking on the Queen Elizabeth, I work with Mark Garvey on quite a number of areas. Mark works at Queen Elizabeth, and they were looking at the taps in their own wards, and they found that 25% of their outlets, and this is in intensive care, 25% of the outlets were positive for Pseudomonas aeruginosa. So quite rightly, they introduced a strategy of introducing water filters. And I love water filters. I think they're a fantastic control measure. You can introduce them very quickly to an outlet you want to keep as a clinical hand wash basin. However, this is one instance, and there are others where we demonstrated, Mark demonstrated, multi-drug resistant Pseudomonas aeruginosa dripping, getting back to that diarrhea again, dripping from the filter. And if he hadn't been aware of that as a clinician and aware of his complete interest in water outlets, he would never have noticed this. They, the staff, were using these because they're delivering safe water that they can use with patients, and yet they didn't know that it had a multi-drug resistant Pseudomonas aeruginosa on the outside of the filter. Please be aware when you're using them. So some of the pragmatic issues we worked with hospital trusts. This was a trust whose water velocity was so great coming out of the tap that it filled the basin up and the water wouldn't run away. The implications are on the left-hand side, we have the filters in place. With the filters in place to reduce that velocity, you still have drops. On the right, we have no filter in place. You can see the V where the person was standing and the amount of water on the floor. All of this, even on the left, led to damage on the flooring. So we were talking about flooring yesterday and antimicrobial floorings. This would damage the floor, believe me. The red spots are very important. That's the areas that were found to be Pseudomonas aeruginosa positive, not when we went there, but on different occasions, even with filters in place. So this is contamination coming from the ward to the outlet and the hand wash basin. And we were talking a lot about, Sanjay said, talking about men with water problems yesterday. So the person who stood on the right-hand side washing themselves looked like that. So he had a real water problem. But fortunately, the filters are in place, but you're still getting splashing. The implications of that were, well, here we go, a hand wash station. We have protocols for not leaving bottles on the hand wash basin, because as soon as those bottles are there, you get dirt, debris underneath. You get microbial accumulation. The importance of this slide is your filter on here, you're still going to get water droplets because of the velocity. This is a preparation area for sterile pharmaceuticals. This is the hand wash basin on the left-hand side. Here on the right is a baby washing sink. Practicalities. Address the problems you have. Don't just let them continue on a day-to-day basis. So has anyone been involved in any CPE, carbapenem-resistant strains work? Okay. So there's some work we've been involved in more recently at the University of Virginia and the University of Manchester. You asked us to put some slides in with references. There are the references. You can look at these later. Basically, it's all drains and water systems that are showing problems of CPE. There's a number of risk factors. The longer you stay in hospital, and more than a quarter of the patients infected die. That is tragic, absolutely tragic. And here's some work which Ryan George carried out at Manchester, where this was a utility sink connected to the ward, where they were finding CPE was present. They ran the water into the drain, and they were recovering CPE on these plates. When they didn't run the tap into the drain, it was negative. So they then took a look at their clinical hand wash basin. You can see on the right-hand side, here's Julie pulling the bottle brush out and how black this is. So they decided to have a look inside the bottle traps. That's the pipe to it. That's the traps. Where did I put my grapes? Anybody want a grape? There, they're over there. If you want a grape, go and help yourself to a grape, but don't put them in your hand wash basin. If grapes are going down there, other materials are going down there, plastics, antibiotics possibly, more than likely. The antibiotic selective pressure on the bacteria in here is going to end up with that clinical hand wash basin being contaminated. And they found their basins were contaminated, the drains were contaminated, so they replaced the whole thing. And then about 3 or 4 months later, they were starting to get positive back again. So what did they do then? This was getting expensive. They had to shut the whole cardiology unit down. They had to pull out all the pipes, everything. The unit was virtually destroyed and then rebuilt. Right back to the stacks. So this is your water flowing horizontally back to your main vertical pipes. And if you don't like horror pictures, look away now. These are probably some of the best biofilm pictures. It goes back to Dr. Weir's wooden pipe, calcium biopipes later on. These are wet, sludgy biofilms, and this one's virtually clogged. So you can imagine that seepage. It's going to be seeping away. It's not going to be flowing away. So that seepage is going to allow the bacteria to grow, the biofilms to flux and move. Some of Katie's pictures about the biofilm sloughing off. These are horrendous. I love this one. This is great. This is probably what you have in your water systems in your hospitals, and we just don't know it. We're not looking that far back. And if you have a CPE problem that's occurring, if you can take it back to the water system, you never know what you'll find. So just sort of touching on sort of 3 main phases just left in the last sort of 12 minutes. Electronic data management. This is something, again, we were very grateful to George McCracken, because like many hospitals, who collects data on Excel spreadsheets? Yeah, okay. So we've got our Legionella, we've got our temperatures, we've got our Pseudomonas, and you just build it up, and what do you do with it? George had his Excel spreadsheets, and he sort of, going back to yesterday, he had a ha-ha moment. Okay, we've got some students who can draw some graphs. He worked with a software engineering company, so they've got their data, they can plot the data, they can look at how often it's occurring, the Legionella, Pseudomonas. They can look at the cost, they can look at the frequency over time, and then you can look at the number of positives or negatives within your augmented care unit. So you can actually plot this, so you can actually make it tell you more, give you more information. Imagine knowing how much your testing is actually costing you. And then your assets, I was talking about assets earlier on. So what George and his team did, he intuitively got a team to go around and make notes of every single hand wash station and outlets, showers, anything that had a water source and had a risk to the patients. And they then plotted that on flow diagrams based on the positives for the microbiology, based on the data for the temperatures, and based on where the patients were when they had infections, which could have been waterborne, such that you can look at that movement of patients around the hospital and try and identify key assets that could have been resulting in positives. Importantly, what he was then able to do is, when he did have a positive, put remedial actions in place, and again, plot that remedial actions which were taking place, and then again, relate back later on how many and what type of remedial actions were actually working for a longer time period, so you could focus in on methods that were actually working effectively for him, his hospital, and his patients. So just to touch on other equipment, there's a whole list of other equipment here. We've all got other equipment in the hospitals which use water. In fact, I was having a conversation with Kirsty yesterday about other equipment that I didn't even know existed. What I'd like to discuss with you is the heater coolers. Is anyone aware of the heater cooler incidents? Mycobacterium chimera? Okay, so I'm just going to touch on some of our interest in this area and the work that we carried out within Public Health England. Heater coolers was first published by Hugo Sachs and his colleagues, and is one by Haller. Contamination during production of heater coolers by mycobacteria showed that when heater coolers were actually manufactured in the plant, that there could have potentially been a point source contamination in the actual factory where they were built, which had major implications later on for the outbreak. But it's still, hospitals still have to be aware of their own water and what they could be contributing to the process. So what is a heater cooler if you're not aware? It's a tank on wheels. On the right hand side you can see here it's got a couple of vents, it's got a couple of fans which I'll show you in a moment, it's got a water tank and a cold tank. The cold tank to keep the heart cool and the water tank to keep the patient warm. And they have 5 to 10 meters of piping. So again, thinking about the surface area, thinking about biofilm, you've got these tanks with 10 to 12 liters of water. Bottom right, you can see the overflow pipe here, which is just full of biofilm. These are just engineering practices. It was never considered that this would be a microbiological hazard. Within the PHE in the UK, we looked at over 47 heater cooler units across 13 trusts, and we were looking at recovering 10 to the 9 CFU per mil, 10 to the 9. We were talking in our breakout groups yesterday about standard achieving a 10 to the 6 reduction. That would still leave us 10 to the 3 microorganisms in here. And in terms of mycobacteria, it's a really quirky organism, and its ability to tolerate, and I'll use the word resist rather than resistance, to resist the killing of a disinfectant is phenomenal. Such you end up treating these systems, you end up with a soup of Mycobacterium chimera because of that cell wall and its inability of disinfectants to penetrate. We were not only recovering Mycobacterium chimera, we were getting other Mycobacteria species, and I know we were told not to look for Legionella. And it goes back to that, when I first started in Legionella, it was like, I'm not going to test. I am not going to test for Legionella because if I find it, I've got to do something. So we had Sam Collins, who's probably one of the best people I've ever worked with in years. Sam developed our PCR at Porton for Legionella, specifically for PHA. And we tested it for Legionella, and guess what? Aha, we found Legionella. So we had to bring in the HSC because it was then no longer just a Mycobacterium chimera transmission and infection to patients. We were looking at potential risk to others within the operating theatre. These units are incredibly interesting. They're generally set up maybe 2 hours before the patient comes into the ward. Therefore, you've got the water moving around the tanks, you've got dispersal. And I'll show you in a moment that dispersal came from as an aerosol. So we were using air samplers, Air Ideal, and the Coriolis as a cyclone sampler to recover the microorganisms from the air, which we did. Importantly, with Simon's a phenomenal technician we have in the department. In fact, he's a fantastic scientist. He started looking in detail at these units and taking them apart. And if you look at the right-hand side, you can see the seals here. And on this one on the left, we found a gap. And then this top plate here, there was a gap between it and the wall. And why was that important? Because that's above the tanks where the water's moving and it's recirculating. We then have a situation where Simon took the top off the tank. So again, gross biofilm inside these tanks. Disinfectants are not going to denigrate this. They're not going to break it down. They're not going to kill the bacteria in this biofilm. Disinfectant doesn't have a chance. At the back of the units where you have the piping from the hot and cold water tanks operated by these levers, you then have a little fan at the back, and down here was that overflow bottle where the biofilm was present. You see the amount of tubing and the biofilms which would form. Unfortunately, we couldn't get the videos to work, but just to wrap up in a couple of minutes. Importantly here you have the levers, and here you have the areas where the holes were present in the top tanks. And here you have this fan. It's just basically a little computer fan. And if I switch to the next one, Simply, Simon just switched the whole system on, used a smoke pen. And you can see the smoke drifting, being pulled across here by the fan and pushed out. So basically, as the water's flowing, it's pulling the aerosols out, and that fan is distributing it across the theatre. So hands up who's associated with operating theatres. Is Andrew here today?
No.
Is he gone? Oh.
He's in Rome now.
Is he?
Yeah,
Lucky man.
He's in Rome already.
Okay, so here we have an operating theatre. This operating theatre had laminar airflow. Laminar airflow is going to come down as a curtain. It's pumped down, the air's pumped down, and it stops anything penetrating the air within the operating field. And the operating field is on the right-hand side. So here you have the unit with the fan facing the operating table. And at the top, the fan is facing away from the operating theatre being a bit in the green. And I'm going to switch to the next slide. And basically, where the fan is faced away from the operating theatre, it's still nice and clear. This is the smoke which has been pushed towards the operating theatre, and importantly pushed through the laminar flow air curtain. So if your surgeons are telling you that they will have no problems in the operating theatre because of the laminar flow, if any of these units are within the operating theatre, in terms of the heater coolers, those fans are strong enough to push the air through and cause microbiological problems. So the solutions have been, in some of the countries, have actually used biosafety cabinets. They built a biosafety cabinet round the heater cooler and maintained it within the operating theatre, and then just basically pumped the air out. And then in others, they've actually removed the heater coolers from the operating theatre and ran the pipes across the floor. I'm sure you can imagine some of the issues this is going to have. But the reason I was asking if Andrew was still here, Andrew is one of the few other people who I've ever had a discussion with who said, have you ever seen the amount of water on the floor with these units? And the amount of water that the staff get on their hands when they're connecting these pipes? And then the staff are touching other areas around about the operating theatre. So it might not just be an aerosol route, there could be hand contact routes as well. I was very impressed that he picked that up. So ladies and gentlemen, that sort of wraps it up for me really. But basically, hopefully I've got across here the importance of the water safety group. The importance of having people like you in this room on those groups, because you bring the expertise that is so important that only you understand the problems which we're encountering. I've been really impressed by the amount of expertise involved in the environmental area that we've discussed the last couple of days. It's not so long ago where you're always pushed to the periphery if you want to discuss environmental contamination. So, team, are you ready for this? Let's do it. Where's Jesse gone?
Hi.
Jesse, what are we going to do?
Well, next up, after you're all set, we're going to have Dr. Gurley-Manatot speak for a few moments.
You can take a seat up at the...
Yeah,
I will, sure.
Thank you so much, Dr. Walker. Let's give Dr. Walker a round of applause.
All right. Stay here.
You threw me off by standing where I like to stand as time counts down, so I didn't know what to do, so I apologize. Our next speaker is Dr. Gurley-Manatot. She is currently in charge of regulatory compliance at 6 hospitals in the New York Presbyterian Hospital Network. There's a lot of groups you work with here, Dr. Manatot: the environment of care facilities, utilities management, emergency management, environmental and occupational safety, infection control, and water safety. You're a safety bard. That's amazing. She also provides regulatory compliance guidance and support for 5 New York Public Hospital regional hospitals as well. She has a leadership role in the 2015 Ebola Readiness Program at New York Presbyterian, and also with Infection Prevention and Control and Facilities team, she leads the Legionnaires Program at New York Presbyterian. Let's give a round of applause for Dr. Manatot.
Good morning, everyone. Thanks for the introduction. And so how's everyone? I'm trying to come up with some light jokes or something that can break the ice. Unfortunately, I'm not one of those gifted, so I'll just write and discuss my discussions. So we'll discuss about, Dr. Walker was able to discuss extensively about the waterborne pathogens in the healthcare environment. What I'm going to discuss about today is not really the details. He did it pretty perfectly, more than I can probably do. So what is the pivotal moments in infection control, particularly in New York City or New York State? So it started when, during the outbreaks of Legionnaires in August 2015 in the south of Bronx. So with that became the sentinel event focus for the need to have a comprehensive water management program in building water system to address Legionnaire's disease. And good enough, just timely also, a month prior to the outbreak in August 2015, in July 2015, ASHRAE 188 established a new higher standard for protections against Legionella. So it's timely, at the same time, it's daunting, especially for healthcare in New York City and New York State. So because of that outbreak, significant changes or emergency regulation was established both by New York City Department of Health and Mental Hygiene and New York State Department of Health. It requires everyone to make sure that all their cooling towers are registered to the system, to the Department of Building, and make sure also that within 14 days after the emergency regulation, all systems must be inspected, cleaned, disinfected, and make sure to establish monitoring parameters. New York State Department of Health also required all healthcare institutions to start on their water management program. So what are the responses of the government and at the same time regulatory bodies because of the outbreak and the increased focus of the people, the media, to what happened in New York City? So New York City Department of Health, after the Local Law 77, have published or adopted the Chapter 8 of Cooling Tower in Title 24 of the New York City Rule. This Chapter 8 Cooling Tower requires an extensive program management of the facilities, which means that a specific microbial testing and reporting must be done. Specific monitoring, maintenance, and chemical treatment must be established, and also reporting to the department if significant changes or from the validation have been noted. New York State Department of Health also requires that annual certifications of all cooling towers must be done, which means that that annual certification must establish inspection, cleaning, treatment, and disinfection. Other than that, continuous monitoring and reporting to the state must be done. One of the drawbacks for this is that it's not just reporting directly or handing or emailing all the results or the significant results to the Department of Health. Anyone and everyone can see the data because it's electronic monitoring or electronic reporting. The good side for us is that there is someone who can help guide us and make sure that senior leadership can provide resources. On the other hand, if other departments or agencies or media will not understand or have the same comprehension of this team here or Dr. Walker, the results may be construed differently. So electronic reporting is also required, which means that extensive training to facilities on how you report out information must be scrutinized and must be properly provided. Refresher courses must be provided because not anyone can understand that putting on 100 CFU per ml as Legionella result for their cooling tower is nothing. But for some, just to get a number is different, which means that the institution you're managing may have a potential causes of Legionnaire's disease for everyone, which may not be true or may be true. So that's how you utilize information is important. So recently in June 9, 2017 as well, CMS released the memorandum SC 1730, and this is a requirement to reduce Legionella risk in healthcare facility water system to prevent cases and outbreaks of Legionnaire's disease. I'm just going to give a brief overview of this, of what requires for healthcare facilities, long-term care, and critical access hospital, because I think we will have someone who's much expert to discuss about the process. But one of the things being required from facilities is for them to establish a water management program. Out of that, you must be able to demonstrate in your policies and procedures an extensive risk assessment. And what does it do? After you establish your risk assessment, obviously providing mitigations plan. And part of it also making sure that your water management program aligns with ASHRAE 188 and also the CDC toolkit. CDC toolkit will help you guide on what is needed in your water management program. I guess if you've listened attentively to Dr. Walker, you will be able to decipher all the 7 elements that the CDC toolkit established on how you will go ahead and proceed with your water management program. It entails about establishing a water management program team, which Dr. Walker was able to identify who should be involved in that process. So I guess I don't have to explain this also because everyone here is an expert and you know where the potential causes or presence of Legionella in healthcare. There are some items also that may be overlooked by some, and some of them because, again, like for example, the decorative fountain, maybe because it's not apparent to everyone about the potential aerosolization of this fountain. I know some of you might be wondering, why am I including sanitizing in this slide? It's not part of your water building system, but I included it because, again, it's not saying I'm not advocating for hand hygiene. In fact, because of the sanitizing for several significant buildings in New York City or New York State that have been built for 50 years or 30 years, every room has a sink. And because in every room also nowadays, you will see a sanitizing solution, they tend to forget that the sink is not available for them to use because accessibility-wise, as mentioned a while ago by Dr. Walker, some of the sink are being covered or obstructed by equipment. So they tend to use the sanitizing and there's stagnation in those sinks. So stagnation, as we all know, can cause, it is the optimal growth for certain organisms, and one of them is Legionella. You have water age, and there's inability to flush all these organisms. So once you expose someone who might be susceptible, that's when you can have the disease. So the sanitizing solution here is just an indication that if you have a sink in each room, if not the patient or not you who should use it, please advise your nurses or your EVS to make sure that they get to it and run it at least once a day or several times a week. And that way, we eliminate the potential stagnation, water age, and optimal growth of these organisms. So again, this has been discussed extensively by Dr. Walker of who should be involved in the program team. A solid water management program enables the facilities the ability to make sure that all issues may be addressed extensively by different departments. There is a clear communication, and all the active water safety management program team must be involved in analyzing, in education the staff, in training, and making sure the implementations of the matrix. Significant obstacles in the water management program is different in each case or at the same time in each institution. Some may have the privilege of senior leadership providing resources needed. Some may have a difficulty with the staff. The staff, as discussed yesterday by Dr. Saint, about some can be the OC, organizational constipation. So those are the things that how you address and how you make sure that they will be involved in your management program. How you circumvent certain things and at the same time because again, circumventing these type of people can be daunting, can be tiresome. And over time, you will just forget about working with them, which means that if you continue giving educations and training to them or making them understand that it can be their process or it is coming from them, as mentioned by Dr. Saint, we will establish and make sure that we will have a good program team. Vendors. How can vendors be an obstacle in your water management program, considering you are paying them to give you services? There are so many aspects that they can be an obstacle, one of which is delaying giving you the results when you need them the most. How do you work about making sure that you get the result before the official statement? Like, for example, in New York City right now, within 24 hours of getting a significant results of your Legionella, if more than 30% of your sampling locations in your domestic potable water system, you need to notify the Department of Health. If you don't get to do that, and at the same time establish disinfection, we have not encountered yet any ramification, but then it will not look good in you when they come back that there is a delay in notification to the Department of Health. So how you work with them, that you get the information timely and get to react immediately because your treatment vendor are not available 24/7 for you because there are several institutions that they're working for. So those are the things that you need to summarize with them on how they can be your partner and not just a vendor that you're paying to provide services to you.
Thank you, Dr. Monatad. We'll have questions at the end of the panel for a few moments before break, so let's hold our questions for them. Our next speaker is Dr. David Krause. He currently serves as the National Practice Leader in Toxicology and Risk Assessment for Forensic Analytical Consulting Services in Tallahassee, Florida. Over the past 23 years, he has practiced environmental science and public health, focusing on the areas of toxicology, occupational health, industrial hygiene, indoor air quality, and chemical emissions from consumer products. He co-authored the 2009 Guidelines for Surveillance, Investigation, and Control of Legionnaire's Disease in Florida and the 2015 AIHA Guideline for the Recognition, Evaluation, and Control of Legionella in Building Water Systems. Dr. Krause.
Good morning, everyone. A quick overview of what I'm going to be presenting today is on using competent professionals to perform Legionella source risk assessments. We can call it a risk assessment. In industrial hygiene, Legionella is one of many microbial or chemical or physical hazards that we look at in the workplace. The Industrial Hygiene Association has recognized that practically every outbreak of Legionnaire's disease has been caused by somebody's workplace. And while it may not have been the employees who suffered the disease, that employment location had the greatest possibility of preventing it to begin with. We're going to look at what constitutes the risks of using unqualified consultants. It's not what you might think. And defining the components of a risk assessment. What are the competent professionals and competent technicians? And finally, what consumers should know. And we're all consumers to some degree. What you should know and ask of any consultants that you may be looking to hire or bring on. The importance is that competent professionals, which is the term we use and define within the AIHA guideline, is that some of these people are going to be developing your assessments and sampling plans. They would be collecting samples and interpreting the results. They may be recommending interim measures either before the sample results arrive or in validation of your disinfectant efforts. These individuals would also be possibly communicating with public health officials, employees, residents, patients, management, and the media. And finally, long-term recommendations for water treatment, system management, maintenance, and monitoring. If you hire somebody or have an expert who doesn't really know what they're doing, all of these can turn out poorly for you. The risks of an unqualified consultant or an inexperienced consultant may include missing the source of amplification entirely and the source of exposure, an increased risk of exposure and disease, risks of prolonging the investigation and the number of cases. We've seen where consultants spent half of their time sampling locations such as air conditioning condensate pans for Legionella, where it's simply too cold or has not been identified as a source of an outbreak. Potential damage to your building water systems from the cleaning and disinfection, the hyperchlorination, the damage that can be caused by. Generation of carcinogenic disinfectant byproducts. And this is an area where we are consistently not looking that systems are being installed either on a temporary or permanent basis that can generate trihalomethanes, haloacetic acid, can leach vinyl chloride from PVC pipes. And finally, the corrosion of premise plumbing and the release of lead and copper from overtreatment or aggressive remediation measures. So there can be real damage that can occur here. I've seen where, frankly, unqualified consultants have been brought in, deemed something to be a problem or not a problem based upon insufficient evidence. And then the building owners or facility managers are stuck with that. I call them liability grenades. That comes back to haunt them later on. So just quickly, what is Legionella source risk assessment. The term risk assessment we've used, as I'm also a toxicologist, and that's our bread and butter. Chemical risk assessments, radiological, physical risk assessments have been used for many decades now. We talk about risk management in the ASHRAE 188 document, but we do not define or even use the term risk assessment. So we're managing a risk that we haven't truly assessed or come up with a framework to do that. So it's not defined in the 188 guidance. It's not defined in the CDC toolkit. So industrial hygienists, occupational health risk assessments is our bread and butter. This is what we do on a regular basis, whether you're dealing with industrial working fluids, lubricating fluids, welding, radiological hazards, physical hazards. Risk assessment is daily in and out what we do. So we actually took a significant amount of time to define the various risk assessments that could be performed, bifurcating it into either a routine versus investigative. Routine being what you're going to do as part of that initial assessment if you don't have any cases of disease, outbreak, or alleged diseases occurring at the time. Investigative being part of an outbreak or investigation, and is to identify potential amplification sites and transmission sources in order to minimize exposure risks. Truly buyer beware. There's no accreditation, credential, or license in the United States that ensures a person or a company are qualified to assess Legionella sources, risks, or effectiveness of control measures. We are all self-proclaimed experts. Buyers should demand and check references of all self-proclaimed experts. Ask for curriculum vitae and resumes. Unfortunately, most experts are hired in the midst of a crisis. The health department says, you've got several cases, get somebody there to help you now. And they try to find the closest person or company available, maybe somebody they've worked with before. That's not how you would hire somebody to do a complex task under normal conditions. So unfortunately, it's often done in crisis mode. You'd want to look at postgraduate and professional education, waterborne pathogens, their habitat and ecology, physiology, pathology of Legionella, potable water systems, understanding the utility water systems, and pathogen control measures. These are the type of things you would want to see in someone who is going to be helping you deal with these issues. So within the AIHA guideline, we actually took a little bit of time to define what would be the competencies and foundations for a competent professional and also a competent technician. I'll go through these quickly. Individuals with special education, training, and knowledge would include industrial hygiene, environmental health, engineering, life sciences, chemistry, or physics, at least 2 years of experience under the mentorship of someone who's been doing this a while, CIH, registered sanitarian, PE, postgraduate or professional education in waterborne pathogens. Again, knowledge of Legionella, assessing potential amplification sites, remediation and mitigation measures, and monitoring and documenting control measures for Legionella. We recognize there will never be enough competent professionals to deal with all the issues we have here, especially as the CMS memo and ASHRAE guidance is implemented. So there should be and reasonably can be different levels of competency. Your maintenance staff, field techs can certainly and should be assisting in the regular checking and testing. And these people should also have knowledge and skills and training on how to collect samples, how to take measurements to assess water systems, valid measurements, reliable measurements. It is truly garbage in, garbage out. If you don't have the information that's accurate and reliable, you're making decisions upon bad information. How to evaluate remediation efforts and how to perform post-remediation measurements. As was mentioned earlier, you want to take your samples at least 48 hours after any disinfection process. One of the things that we saw with the cooling tower assessments in New York City, if you take water samples from a stagnant, non-operating cooling tower that is contaminated with Legionella, it's critically important to know that the water circulating pump is running, because you can go from non-detect to hundreds or thousands of CFU per mil by simply running the circulating pump. Without that definition, without that requirement to say if you're going to take these samples, ensure the circulating pump is running, I can assure you some of those samples are being taken with a system that's not operating. So some small things like that can result in false negatives for your sample results. The interpretation, however, of sample results should be left to a competent professional. Minimum qualifications may include high school education, training on how to collect samples, personal protective equipment, and exposure assessment. And similar competencies as we described for the competent professional. However, at probably more of a one-day training should be sufficient to teach somebody how to take data and collect samples that are reliable. The industrial hygiene approach to Legionella prevention essentially consists of our entire approach is that it is defined as the science and art of the anticipation, recognition, and evaluation and control of these environmental factors or stresses arising in or from the workplace, which may cause sickness, impairment, health, and well-being to workers or among citizens of the community that we serve. We are not here just to protect the workers at the plant or the office workers at the building or the staff at the hospital. It's those people who come near, work with, the families who may have take-home exposures as well. And in short, we essentially recommend that amplification sites, reservoirs, and sources of exposure be proactively identified and validated, reliable lab methods be used to measure viable Legionella bacterial concentrations. Secondary water measurements used as indicators should not be relied upon to validate control measures. They can be used to verify that what you're doing is that you're doing what you say you're doing in your plans. But if you want to validate that your system is actually controlling Legionella, you need to test for Legionella. Validation is part of a three-legged stool. It's not what's expected, it's what's inspected that is done. Unintended consequences of water management and treatment by chemicals and heat. You have to consider the disinfectant byproducts, the downstream impacts, the corrosion of the system, the releasing and leaching of metals from pipes, as well as the generation of vinyl chloride, a potent carcinogen, inside building water systems. And this is not currently done on a regular basis. We need to consider the accelerated degradation of building components. If you install supplemental treatment systems, it's not uncommon to have increased pipe leaks by 30 to 40 fold in the coming year. So old pipes, they basically get older very quickly. Need to watch out for potential conflicts of interest. This was touched upon earlier. Firms that treat water, they may focus on chemical treatment. Every carpenter, every problem is a hammer. One-stop shopping poses a number of risks. Turnkey operations inherently are not allowed within lead assessments, mold assessments, asbestos assessments, yet they're being currently allowed as it deals with Legionnaires. There's no prohibitions to keep those who are performing the maintenance or remediation from grading their own homework. Over-reliance on a single mitigation approach or technology. My golden gun will fix your problem, and rarely is that ever the case. These are multivariate problems that require multivariate fixes. Frankly, you should ask yourself, what are they selling? And who will actually be doing the site work? Because many, especially the larger firms, have not cultivated the expertise within their organizations and are subcontracting out that expertise to smaller firms. So you want to understand who's actually going to be on site doing the work and consulting for me. And what is the scope of work and what guarantees are they offering, if any? I'll quickly go over a few Legionella amplification sources. Basically, avoid the sources you can avoid the exposure, have the greatest potential to avoid the disease. Equipment-mounted water, these are some areas that, some sources people may not have seen before. I'm going to zip through these, but water tanks such as pressure washers, when they become contaminated, they can create quite an aerosol. showers, especially those that are infrequently used and that have the flexible hoses. Great place for amplification to occur. Decorative water features. Garden hoses, hose bibs, and we do find these at commercial facilities. These are used to spray down decks and to feed water pressures. This one was sitting out in south-facing exposure in Florida. Absolutely no chlorine in it. Hand washing stations, especially those that are called Bradley sinks or the deep water sinks. This is an example of one that could not be decontaminated. The inner tubing of it was too convoluted and difficult to decontaminate. Electronic eye faucets, a lot of the times there is absolutely no maintenance going on in the solenoid and the screen mesh devices that are used to protect them. And of course, fan-mounted misters, intentionally generating an aerosol. And humidifiers, especially specifically not the steam humidifiers that actually create steam, but the small portable ones. The ones you see here on the left was actually the result of or caused a massive outbreak in a ski resort. Thank you very much.
Thank you, Dr. Krause. Our final speaker in this panel is Dr. Molly Scanlon. She is an environmental and occupational health research scientist, as well as a licensed and certified healthcare architect at the Melanina Zuckerman College of Public Health at the University of Arizona. Dr. Scanlon's research involves examining the built and natural environment impact on human health with an emphasis on healthcare settings. She recently contributed as an author and content developer for the CDC Legionellosis Prevention and Response online training grant. Additionally, Dr. Scanlon is participating on research teams focusing on reducing hospital-associated infections through analysis of occupational stress risk factors for healthcare personnel. Dr. Scanlon.
Thank you very much. Thanks for having me. My only disclosure is I'm with her, and that's Dr. Reynolds. Hopefully you got that joke. I don't have any other disclosures. Like Dr. Weir, I will take all contributions. So if I was going to write a research statement or a question, I would say from a public health perspective, water management programs need to move upstream, pun intended, by using an evidence-based design and construction solutions. We need to be included. So I practiced for 25 years as an architect building hospitals, and I've specified almost everything that has been mentioned in the last 2 days in a building, including medical equipment, down to every hand sanitizer. And it was left to me as the design professional to make that decision. And I doubt many of you in the room know that a lot of things are turned over to design professionals to just put in place. So some of the products that these people are mentioning, if they don't work or they've never been tested scientifically for these things, they just get put in. And that would be a horrible thing to have. So I feel that in public health, we talk about moving upstream toward better solutions and prevention. So I want to try to make that case to you today. So some of the background is, as a design professional, we're educated in aesthetics choices. So there's another discipline of research called environmental psychology. And that involves the environment related to natural light, exposure to nature. So one of the people that, Roger Ulrich, who was at Texas A&M, did a study about patient care back in 1984 about views of patients from patient beds out a window. And there were folks that saw nature, and there were folks that saw a brick wall. And he showed that medication was reduced and the length of stay was reduced, and actually nurses got better, what would now be called patient satisfaction scores, because they were able to see nature. And so that's what brought exposure to nature. And he didn't look at water, but suddenly that seminal study from 1984 led to hundreds and hundreds of studies about bringing the natural environment into the indoor setting, including decorative water features, including soil that is fed with water. And although Roger didn't intend all that, there's all these unintended consequences of bringing these elements in that the design professionals are not aware necessarily of the science that is involved in that. So the other aspect of what's been going on, so you've seen a few charts today starting from the date about 2000 of an amplification of Legionella. Is anyone in here familiar with LEED? How many hands know what LEED is? So you might know nothing else about architecture, but it's somehow the entire United States knows about the most successful program of sustainability called LEED. I'm not against LEED. I'm not LEED certified. However, the date of LEED for sustainability dates to 2000. And so we've convinced the United States to conserve water, but we haven't convinced them that it's safe. That's a problem. So I'd like to introduce a word to you about life safety. So in my business, life safety, and actually Dr. Weir posted something about fire safety. So if you were life safety in a hospital, wouldn't you think that would include all the systems in the hospital? Because we're trying to save people's lives. And especially in an emergency crisis, you would think it would involve all systems. Life safety and building codes involves fire. That's it. Does the building stand? That's it. Water system, not protected. So we've got an electrical power in California, where I'm mostly have done my practice, and also I'm registered in Arizona. Electrical power and other systems have what we call redundant systems. They have backup systems, and they're mandatory, so that when something goes down, do you want to be the patient in the operating room where the power fails? Probably not. And you wouldn't want that with your water system either. But there's nothing actually to say that it needs to be protected during that time period. So there's this minimal addressment of water quality, but we spend a lot of time establishing very expensive systems that are appropriate for air and smoke compartments, because in a healthcare facility, your first area of refuge is what? To stay in the building. Say that again? Defend in place. Defend in place. So it's to stay in place and move horizontally through the building and not to exit, because you can't take all the patients out. So that's not true. So if this building was burning, are we all staying? No. We're leaving, because this building probably has only been rated to an hour. We have 1 hour to get out of here, and that's about it. And that's true for high rises, and it just depends on the various states and codes. But anyway, we don't really look at that. So now we've introduced these new standards of ASHRAE 188 and the CDC toolkit. They're being adopted. I call it being adopted by reference. So a local municipality could adopt these standards, a state could adopt these standards, and you've heard that like CMS or a regulatory agency could adopt these standards by reference. So it'll be based on what happens in your state, or if you're receiving reimbursement from the federal government, then you're going to be complying with these memos. So in water safety and building codes, it's unregulated after it enters the building. We kind of assume that this municipal tap just is continuous throughout the building. And the lead emphasis on the water conservation is not necessarily addressing safety. So we have minimal looks at prevention and issues addressed kind of after the accident happens. David said most people are called in at an outbreak, and that's not the time you want to be making these kind of decisions about very expensive things, or even remedial repairs, et cetera, et cetera. So we need to look at water quality at a much more serious level and much more early in the process, not just at the outbreak. And that's in the public health, what we call moving the intervention upstream. So there'll be a panel this afternoon talking about this, but construction in and of itself is what? Messy, okay? It's messy, dirty, and toxic, not only for the employees of construction, which is not always looked at either, but imagine all of the dust. I have several stories of other things about air quality and things that have actually killed people in hospitals when construction was underway and things were not, a safety officer didn't go through and wasn't doing standard checking of that construction site. And that could happen with water. But we also don't look at what's happening with medical equipment during this time period. I have an actual client or former client in architecture that has been under construction for the last 5 years. They've had 3 different general contractors, and everyone has come in and busted the main water main on the site. There's absolutely no monitoring of that construction or the water quality that happens. And the facility manager just said, when the nurses came out with the brown bottle, similar to the Flint thing, looks okay, go ahead and use it. That's what was actually said. And the nurses just said, no, looks like Flint, I don't know what it is, put it down. And they went to supplemental water supply, but these decisions were being made in just seconds of what was happening because water was completely lost in the building. Where's the supplemental water supply coming from? So there's a lack of what I call testing and recertification of a water line during construction or post-construction. And we monitor air, we monitor other things. Why can't we do that for during construction? Water lines should be. You can't touch an air line that's going to go back, meaning a certification of air for medical gas. You have to recertify that line once it's been touched. Why isn't that being done for water? So I think that we should be introducing interdisciplinary voices, including the research and design of profession and policy initiatives, raising awareness, including design and construction professionals, as well as medical equipment and planning procurement. As I mentioned, I was a medical health planner as the role of an architect, and I specified every single thing you've mentioned: floors, walls, curtains, and there's interior designers that are all involved in this. They're specifying all these materials, and they may or may not know there is an educated workforce in that as about healthcare, and they really do try, but they're not exposed to the science level that's exposed in this room, and we need to include some of them in these conversations. They need continuing education, and they need to understand what water management team programs are. So something Dr. Reynolds and I have been discussing is we went through and actually did the case studies on the CDC toolkit that's not yet out yet on this online training, and we found ourselves being educated as a team, and we realized you can't do this by yourself at all. You couldn't even try because we needed so much expertise around our team, and it was just an excellent example of how that works. So we want to talk about how we're going to address new construction and renovation and not just existing buildings. So on the team that I was on, everyone's like, well, we just deal with the reality of today, and that's your existing building. And I totally understand that. But for someone like myself, who in my past was hired to come in and predict what that problem was, I'm often asked what design solutions are going to be set forth to avoid this moving forward. And water is a very destructive force in any type of situation, let alone what we're talking about with Legionella. So I think it's just very important that we look at future buildings. There's, a lot of replacement of buildings. In California, we had earthquake standards that were massively replacing these buildings, but we might not have been looking at these other types of systems that would cause more harm, basically, than the earthquake would. So I've been thinking about and talking to Dr. Reynolds about establishing something I call the Legionella Nexus, and this is about engaging industry partners and design professionals to actually be educated in this. And really, would we look at it, in my business, we call it a building materials science. So what are these materials in the building? What are they composed of? How could we incorporate? We've heard several great examples from my engineering colleagues in the room of how do you design a solution? How do you modify to design a solution? I've heard in my discussions with some product vendors how we could use engineering solutions in their product design and maybe test those. You have to look at technical specifications. So as a design professional, we don't just deliver a set of drawings, we actually deliver a set of technical specifications that could also enhance mandating that some of this testing is occurring and how. And so therefore there would be multiple checkpoints throughout the process, not just what's written in 188. You can enforce that in another way by driving the technical specifications of the building upward. Commissioning standards. So if we are going to do water conservation, then what is the commissioning standard of handing those over? How are the maintenance and operation manuals being handed over? And what is the commissioning standard? So we should be reshaping our water sustainability to include safety. We need to look at policy and building codes and maybe a redefinition. I don't know that I can redefine the NFPA's life safety word, but I'd like to see that expanded to include all the systems from a general understanding and not just fire and structural. I think there's great opportunities in plumbing fixture design. A lot of things, we don't need an aerator maybe in certain locations, but maybe these fixtures should be redesigned and relooked at. And we also need to look at the workforce. I love the concept of looking at families and what's happening with them. So we look at the healthcare workforce, but as far as Legionella and the CDC toolkit, this is for all buildings. So I think we need to think that health is not just always in a hospital. And I know that that's our primary target here, but we have luxury hotel spas that are about healing environments, and they're doing all types of alternative healing. And then there are some that are, Melanie and Zuckerman are the founders of Canyon Ranch. And so, I've thought about that we ought to be talking to them about a water management program. But I mean, you have to start looking that health really goes beyond the hospital. And there's a lot of things happening in outpatient settings that really need to be addressed. And so we're doing major operations in outpatient settings that we weren't doing 10 and 15 years ago. So all of that, I kind of put the fish up here with his shark fin on. And so we need to come up with more creative types of solutions to bring our team together about what those can be. And not just, I know the hospital is the acute setting, but we've got so much more going on in healthcare and medical office buildings. So kind of my little summary here is that we need to move upstream. And so to me, the downstream approach is water management programs that are looking at the cases and outbreaks. It's already happened. The midstream that we call in public health, to me, is looking at the existing buildings and trying to do something with them. And the upstream is trying to look at what the new buildings are going to be doing and what the prevention is going to look like. And we need to be looking at the full aspect of that across our public health program. So I thank you for your time, and I'm assuming we're going to open that up to the panel for questions.
Thank you very much, Dr. Scanlon and the other panelists. We have time for some questions as we move into break.
Good morning, Russ Armstead, Livonia. Great job, panel. Just off the chart, incredible information. You've covered the depth and breadth that I hadn't even thought of in terms of those concepts of design of healthcare facilities, kind of new and old and existing. So I think that is. Are you involved with FGI, Facility Guidelines Institute? Just curious.
I am not personally involved in FGI, although I have used FGI, and I have the full respect of that organization. I know the history of that code. It evolved, for those you might not know, from the American Institute of Architects and then was taken over. It's adopted, and I think I might be wrong, about 40 out of the 50 states. And because I've been getting my doctorate, I'm hesitant to say something about the guidelines specifically because I haven't read the most current guidelines. And so there's some folks, I think, in this audience that are much more maybe knowledgeable about specific things that people have been asking me about with water features and Legionella. Although I would say my goal would be we need to get some more science on the review panels for that code so that we can kind of make that a complementary building standard that's going with, ASHRAE 188, et cetera, so we don't have conflicting potential for that. And my whole thing in the beginning is that codes typically, they don't address aesthetics. We're not licensed to address aesthetics. That's why we have poor visual architecture. But we're licensed over the health, safety, and welfare. And so we need to beef that up to be complementary to all the other things that are coming out. That would be my comment.
So my question is for Dr. Krause. I apologize. I haven't read the AIHA standard in a few months, but I was wondering, can you remind me if somewhere in the standard it talks about how, if the building is going to treat the water, if there's any direction to folks using the standard to understand that if they do something like that, they may become an EPA utility at that point?
No. That actually was really coming out about the same time as the guideline was being published. It's certainly on the to-do list for the revision that we're currently working on. But that has been very regional specific. Some regions of the US EPA have begun enforcing that. Others have been very complacent with it. I think it's inevitable that that's going to be the standard of care as they move forward. But we do talk about the need for certainly complying with FIFRA, the Insecticide, Fungicide, Rodenticide Act, ensuring that the products that you use are licensed or registered for that specific use.
I just wanted to make one comment about that, is that I was at a water conference and the Texas Water Authority was there. And when she heard, she was not aware of the treatment inside of buildings of being additive to water. And she was like, I feel like, I don't want to alarm people, but I feel like I need to run out of the room and call the EPA. Because she said, there is no one that can add chemical like this to water, potable water systems And she said, this is very alarming. So she was like sitting in a room sort of absorbing all the information that we're absorbing, but she was an actual, Texas, representing the Texas Water Authority, and she was like, wow, I think I need to go back and digest that. And so
Yeah.
that was a sobering moment for me, who was being introduced to this. I was like, wow, she was very alarmed, as if you were looking at any type of federal regulation that was being violated.
And I mean, it is a reality check for regulators who haven't run into this. And one of the things we make sure that we do is, if you're doing any shock treatment or ongoing treatment of the potable water system, believe it or not, you still have to check to make sure there is a backflow preventer installed. We are still finding buildings today that have absolutely no backflow preventer, or have just a check valve which cannot be certified, can't be trusted as a backflow prevention device, and you don't know that you're not inadvertently treating the rest of the water system. So in the real world, there's a lot of infrastructure that is aged and needs revision.
Gentleman at the back.
Interesting, just point on EPA primacy. I've worked with the Texas EPA and TCEQ for 15 years, actually, as a primacy agency in treating domestic water systems for Legionella. So they, even amongst themselves, they're not talking.
Good point.
It's a continued issue within primacy agencies that some do not have the resources in which to embark upon this path to treating domestic water systems. It's simply too large of a scope for them. My actual question, though, is targeted towards Dr. Walker. Pseudomonas is of growing concern. Obviously, the UK is a few steps forward above where the US is in terms of monitoring and actually addressing the issue, but it has been included as part of CMS's update or memo. So I'd like to ask the question, as far as environmental progression of Pseudomonas. It is a nasty pathogen, and one in which there are multiple vectors of transmission. We talk a lot about the source being the water, but it can also come from individuals to the water supply. During your investigations, did you investigate the probability of human contact driving contamination of the fixture and then backfeeding into the water system?
Yes, sir, we have in fact carried out studies like that, particularly with, for example, cloths used to clean the basins, so microfiber cloths. And you would like to think the protocol would say clean the faucet and then the rest of the area and the drain last, but unfortunately you still see the protocol is not being followed, and you see the drain hole being cleaned first and then the rest of the unit and the faucet last, and then they use the same cloth in the next sink. So that's a potential route. The other potential routes are where, for example, I talked about point of use filters, where these are inappropriately fitted, where there is not sufficient activity space left within the basin for the practitioner to wash their hands. And then you have the waste disposal down the clinical hand wash basin, and leading to the contamination of the faucet itself. So it's not just one direction, as you point out, but it's a multifactorial.
Thank you very much for that talk. It was really informative. I have just kind of like a shameless ask with this expert panel about water management, but we've been dealing with the heater cooler issue, and our architects have come up with a cabinet to contain the devices, but now I need to test it. And unlike Hugo Sachs, I don't have the ability to do that in my office. So I'm just wondering if there's expertise out there, if you know of places that do this kind of work, because I really would like to test it for both Pseudomonas and Mycobacterium and make sure it really contains everything, but I don't have the ability to do that on site.
Industrial hygienists have done this for years. They do it for every type of biosafety cabinet, chemical fume hood. There's an ASHRAE standard for testing the efficacy of a laboratory or industrial containment device. I would start with that to make sure if you can contain aerosols generated in there, and you can make sure that it's generating the airflow velocities, and you don't have cross-directional airflows that interfere with it. That would be your most quantitative approach. Moving on to organisms, you have to decide upon a surrogate. Sometimes they'll use a surrogate, but there's no validated method for collecting Legionella, at least, in air samples because it often doesn't survive the sampling methodology or sample collection methodologies.
Yeah, I haven't been able to find a good surrogate. So if anybody has a good surrogate, I would love to.
Bacillus thuringiens is one that's commonly used for biological materials, but I don't know that I'd want to do that inside of a surgical suite.
We heard a lot from Dr. Reynolds just said about phage, bacteriophage. That would be another biological factor you could use for that testing.
Last question from Dr. Streufels.
Yeah, one of the things that I'm really interested in, and we sit here and talk about the wonderful things that we can do, but the reality is that 99% of our buildings in this United States are built on a punch list basis, and so what happens on the first floor, commissioning our sinks, making sure they work, and going up to 15 floors while those sinks on the bottom sit. We're reducing water usage. We've gone from over 200,000 gallons of water a day in our 450,000 square foot building down to 70,000 gallons of water a day. We're putting flow restrictors in our water lines and slowing it down so we're maybe not even scouring our pipes. We got a lot of work to do, and that's what really needs to be looked at, because water conservation, while it's good, is really taboo if we try to rinse, which is the simplest thing to do. Our engineers put up the cross arms and say, no, we can't waste water. So what are we going to do?
Well, I'll just give you an amen on that. In the field, we are seeing the impacts of water conservation efforts in everything from manufacturing facilities, aircraft hangars, office buildings, hospitals, nursing homes. There is a mismatch of design versus functionality in the field. And we're seeing where 100% of the outlets, water devices in multiple facilities are heavily contaminated with Legionella. That the best thing we can point it back to is lack of water use.
Yeah, I guess I just want to say that, and preliminarily in talking to an industry partner that might come into the Legionella Nexus, the minute he understood the problem, he was starting to try to solve it. And he said, we've been designing pipes this big, for X amount of water flow for what you're talking about. And he said, now we're down to this much water flow. So we need to work on putting recirculation into place or whatever. But we've done this, as I said, fantastic job of convincing everybody that conservation, and I can't prove this yet, but I do want to do some either systematic reviews of the literature and kind of look at this amplification over the same time period that we've been looking at conservation to bring that up, because the CDC does not mention stagnation and other people don't mention it as big of a problem, but we're really over-conserving and we need to run this water as part of its safety. But I do think there's engineering solutions, but the problem is you've got these very big, expensive buildings in place. I'm not sure what that interim solution is to make sure that you're not creating another unintended consequence.
And just to add to that, I mentioned within the UK guidance, we've now gone to 12 hours supply of water. And a lot of people was very, very surprised by that. But it's thinking about reduce the water storage in the first place and then think about the number of outlets you actually need as opposed to the number you think you need. Because there are a lot of outlets out there that are not being used appropriately.
All right, a final round of applause for our panelists.